So, very good morning. Now, this is the third day of our session on the heart. Now, see, from today, we'll be making some changes, some small changes. Once we complete our topic, right? Once the topic is completed, we'll be going for a complete revision of that topic. No doubt, this would be a high speed revision, maximum 5 minutes. So within 5 minutes, we'll be revising all the points, right? They will be in the form of like brain mapping. That is all the keywords and the main concepts, they will be quickly revised. Say tomorrow we'll be taking physiology. Now physiology would be a massive topic. We'll be covering lots of grounds. So many topics would be covered. Today also it is something very important. So what I wish to explain is that on the first day when we talked about, say, anatomy, right? On the second day we talked about embryology. Today we'll be diving a bit deeper into that, right? We'll be discussing some development aspects, plus we'll talk about fetal circulation. And tomorrow it would be physiology. Now after that there will be gap of 2 days, right? So we won't be meeting on 31st and 1st, these 2 days. So what you have to do is you utilize this time for all these sessions, understanding those sessions and revision of those sessions. The idea is that when we come back, when we start our rest of the 6 days, that is from 2nd all the way to the 7th, so 2, 3, 4, 5, 6, 7. These will be the days when we'll be starting with ECG and then congenital heart disease, right? Part 1, part 2. Then we'll be talking about pharmacology, myocardial infarction, and other cardiac ailments, right? So that way, as we will be discussing all these clinical aspect, so first 4 days, if you have revised and you have completed properly, it would be very effective. One more thing, as I got few phone calls or emails about and some suggestions also. One of the suggestion is that, say, even on Quora also I got that in medical science, that is in the MBBS, in the medical education in the MBBS, they said, one of the person asked that I was doing quite well from my 4th standard to 12th standard. Everything was fine. But the moment I came in medical, things are so difficult, it is so overwhelming. Means the amount of information, the amount of knowledge which is to be acquired, to be remembered, it is so much that I am unable to cope up with. Yeah, this happens, right? This really happens. And one of the friend over here, someone from your group only asked that how should we really plan, right? So I promised, as I was reading my own comments, I just read that as I promised that we shall plan a session on how one should really schedule their their entire study pattern. Now if you really plan this very properly, and I completely agree that whatever we plan, it never goes 100%, but it is definitely better than, say, we plan 100% and at least even if we achieve 60%, then also we are way better because we are going as per plan. If we don't plan, it's like not running the race at all. True. So let me know, say, as such, this session won't be at all, say, a burdensome on you, right? All these sessions of the heart, they are like, yes, you have to understand, you have to give some time also. That's why I planned for that revision, so that you can do it effectively. But for this session, we can surely plan it either on 31st or 1st, right? Just let me know, so we can definitely do that. In that, we'll be discussing this part, that's your entire day. And in that session, I'll be keeping the chat live in such a way that when I ask any question, you definitely answer that. Okay, it's like first question would be at what time you wake up. Now even if you wake up at say 9 o'clock in the morning, right, that is totally good, because I would really like to see that you plan your day effectively, you utilize your maximum highest energy level so effectively that you get the success. And I'll not be telling you that you have to study for 18 hours and 20 hours. No, I won't be telling that. My requirement will be just 2 to 3 hours. This should be your undivided attention for your studies, because as such you are studying for rest of the entire day, right? I know that you are an intelligent and responsible person, but when it comes to say devoting this time, this is the time which would be purely for you. So I'll show you some things practically. We'll even consider, I don't mind even taking some of the topics, right, as an example, that if you revise it in that proper manner, you will be so effective in a long run, right? Because see, as we said, that your MBBS journey, it is not at all a sprint, it is like a marathon. And I don't want that at any stage you should be tired and you try to give up. No, no. Means till you reach the finish line, I'm with you. Okay, so this was a plan. Let me know whenever you wish to plan for say this particular session, even on 31st, first, even later, whenever. Just let me know in the comments and we'll plan accordingly. Okay, all right. So today we'll be discussing two things. That's our day 3. One, we'll be diving bit deep into that embryology part, especially those arches. Yesterday, for those aortic arches, we just touched it. We just took some of the important points. Today we'll be going bit deep and then all the way to that fetal circulation, right? Because this is so important. And actually this fetal circulation will be a sort of revision of what we studied yesterday, right? It would be a revision of that embryology also. Okay. So let's start with our today's topic. First, development. See, this was nothing but all those primitive heart tubes, 2 separate heart tubes, and then there was like ventral aorta, first aortic arch, and the dorsal aorta, and they are like present on both the sides, because we saw that as the heart tubes develop, right, heart tubes develop, so they have something as an input, something as an output, right? Inflow track and the outflow track. 31st is okay for this? Sure, I don't mind, right? Just let me know, right? So all of you, if it is fine, so we can put it on 31st, same time, right? 31st, same time, 10 o'clock in the morning, we can. Just let me know. By the end of today's session, right, we can plan out. Okay. So over here you have to remember 2 things. One, this heart tube, and there is aorta, but it is on both the sides, right? It is on both the sides. So when we are understanding it, right, this heart tube and aorta, what exactly are we trying to achieve, right? What we are trying to achieve is, let's see it over here, right? I'm just erasing this so that we get some space, right? So this is what we really want to achieve. That from heart there would be aorta which would be coming out. This aorta is not in 2D, it is in 3D, right? That means this portion, that is the portion which is we call it as an ascending aorta. This ascending aorta is ventrally, it is in front, right? Then this arch actually goes back, right? So it goes back this, and this descending aorta, this is posteriorly situated. So this is posterior and this is anterior, right? So if I watch it from the side, right? So let's say this is our anterior view, and if we watch it from the side, so we see that yes, exactly this. So this is anterior and this is posterior. So we see that from anterior this arch goes on to the posterior part and then it goes down, right? That's like, say, we can say this is the spine, just for the reference. This is the spine, right? And over here this is anterior, so that's like our right and left. Okay, so this is the importance. So our initial part, this is what is called as the ventral part, and the descending aorta, that is called as the dorsal part or the posterior part, and in between is our arch. So same way here, ascending, and that's how they are divided. What we want more, that is in adult there would be branches. These branches would be like brachiocephalic trunk, that is on right side. On the left side there is common carotid artery and there is subclavian artery. This is on the left, this is on the left. Why it's happening like this, right? Because then this divides and this goes, right? So here the common carotid artery, in case of right side, it goes from brachiocephalic trunk. So why it happens that this extra piece is developed, and why it happens that it only goes on the left side? What happens to the right side of the aorta? Will it really go on the right side? Now all these questions, right? How it really forms, why it happens that trunk, right? I'll change the color, right? That trunk, pulmonary trunk, it goes underneath, right? And it is like this, right? So aorta, right? Aorta over here, it would be like this, right? So because from here to it goes back. So why it happens like this, right? It goes underneath. All these answers, right, we'll see over here in its development. Okay, so first thing first, that is on right side as well as on the left side, we have got ventral aorta 1, aortic arch 2, and the dorsal aorta 3. They develop on both the sides, right? Heart tube, though, we have learnt, from which the ventricles and the atrium, they are developed. Now see this. This is how the tubes, they will be fusing, right? So these tubes, they fuse, and now it is like single heart tube, which will not be touching right now. But we see that in single heart tube, the outflow tract was the aortic sac. That's right? Yesterday we saw that it was the aortic sac, and that aortic sac has got two horns. So we call it right horn and the left horn, right? So they are coming out, nothing more. So right horn and left horn, and then once again say this is first aortic arch, that arch, and it is the dorsal aorta, and it goes on both the sides. So nothing new, almost same, right? On top of it, we also saw that those mesenchymal cells, they keep on developing, and then they keep on developing and forming those new branches, right? They sprout, there is sprouting of new arteries. So that's what starts, and now all those new new vessels, right, they start developing, right, they start developing, and we call them arches. These are all arches, and we give some number. So now situation changes. Previously just the dorsal aorta, and now we have got all those aortic arches because all they are part of aorta, right? So that's why they are called as the aortic arch. Arches. We give them the number 1, 2, 3, 4, 5, 6. Same is on the opposite side. So over here also 1, 2, 3, 4, 5 and 6. Immediately you'll notice one thing, that the color of this number 6 is different. True, right? We'll come to that. As we said that the fifth one is going to disintegrate immediately. So that's why that is the point which we can say understand instantly, easily. So it is removed. So now we have got 1, 2, 3, 4 to be taken care of, and obviously the sixth, but sixth is in different color, so we'll keep it aside, right? So here are right dorsal aorta and the left dorsal aorta. They both fuse, and this is what is called as the fused dorsal aorta, right? That's the fused dorsal aorta. Okay, let's move further. The first arch, it means we are talking about this, right? We said that that also disintegrates and it leads to one artery. It leads to formation of just one artery, and that is the maxillary artery, right? So it forms maxillary artery. Same thing happens with this second one also. This second one also, it degenerates just a small stapedial artery which is formed. So practically speaking, we have got one important set, that is 3 and 4, and another one important arch, that is 6. So our entire focus would now be on 3, 4 and 6, because these are the important ones, right? 3, 4 and 6. At this point we go back to our understanding of the last stage of that development, right? When internally what was happening, that all those chambers, they were developed, right? Those chambers were there, but then into those chambers, that's the right ventricle, that's the left ventricle, and over here the blood which was, it was the mixed blood which was going in there, right? It was mixed blood because there was no development of that aortopulmonary septa, because then and then it happens that this left ventricle would really go into aorta, and this blood from the right ventricle would actually go into the pulmonary trunk. True? Previously it was not like that. So then the development of that cushion, right? That cushion develops, which is on the right superior and the left inferior, and then that cushion develops and it extends, it develops a septa, so that now we have a clear passage for aorta as well as pulmonary trunk, right? So because it rotates, so it is like that twisting. This is the reason that aorta, the entire relationship, it goes like this, right? It goes like this, right? In this we make this simple, and it is simply that 3 and 4 arches, they will be leading to formation of this aorta and this pulmonary trunk, that is number 6. That's the reason that this aortic arch 6 was colored in different way. It was colored in white, right? So when it was colored in white, we said that it is for pulmonary trunk. Obviously this will be for aorta. So our today's purpose is let's see how this aorta actually forms, because over here in this image, so it is on both the sides, right? See, this is the number 6, the pulmonary aorta. It is only for arch number 6. Okay. So first arch we talked about, it is the maxillary artery, all right. The second arch, it is stapedial artery. In fetal life, it stays for some time and then it goes away. Well, it contributes to formation of ECA, that is external carotid artery, right? External carotid artery, some role. Number 5, it disappears, so we need not worry about that. Third and fourth arch, they are the ventral part of aortic sac, so that is what it would be forming. And number 6, that is the dorsal part of aortic sac. So ventral part and the dorsal part. Ventral part, that will lead to formation of aorta, and the dorsal part will lead to the formation of pulmonary trunk. This is what I am talking about, right? So this is third and fourth arch, and this one is the sixth arch, and that's the aorticopulmonary septum, that is the spiral septum, which is actually making the difference between both of them. Okay, so to produce adult pattern of arteries, so this figure is as such explaining everything. All you have to do is you have to follow the number, right? So first 1 is over here is 1, and this pattern will follow it in this way, that say maxillary and stapedial we have talked about, and this number 5, it disintegrates, that also we have talked about. So those portions, they are covered. Now we start with 1. Our first point is that on the right side, as well as on the left side, because this number 1 is appearing on both the sides, we have written it on both the sides, between the arch 3, that's the arch 3, and the arch 4, the portion of the aorta between 3 and 4, it degenerates. So that's why we have put a cross, and it is marked over here that which area we are talking about. We are talking about this area. So that degenerates, this area, right? That degenerates, right? That degenerates. It is now no more. So it means there would be a gap, right? The portion between 3 and 4 is removed. The name is Ductus caroticus, right? So that is the name, Ductus caroticus, right side and the left side. Will it matter? Yes, it would matter, right? Ideally, it should be disintegrated. But if it is not, if it stays back, so then there would be all unnecessary shunts, right? Because the blood would be going on some incorrect channels. So that is what we'll see into the CHD, congenital heart disease. But first we need to understand what is normal. So this is the first important point. That is ductus caroticus. This ductus caroticus is third and fourth. That is removed. Okay, that was easy. The second point. The second point is, this is something which is happening only on the right side. It is not happening on the left side. But this is the clue. This is the reason that why we get the aorta, it being so partial, it only goes on the left side. It only goes on the left side because right sided, the entire portion, it is disintegrated, right? So only on right side, and all the way from fourth to the fusion point. So here is the fourth, right? Here is the fourth, and here is the fusion point where both of them meet. This entire portion is disintegrated, so gone. This entire portion is gone, right? So when this entire thing is gone, it means there is only availability on the left hand side. So this is gone. So actually the whole portion which is disintegrated is from third to fusion, but third to fourth was called as ductus caroticus, and it was occurring on both the sides, and this is only on the right side, only on the right side. Good? Okay. So that was the second point. Moving on to the third point. In third point, there is something so interesting and so important because it would be covering in say embryology, it would be coming in congenital heart disease, it will be coming into fetal say circulation, and over here also, and that is nothing but the ductus arteriosus. And whenever you discuss congenital heart disease, the PDA, that is patent ductus arteriosus, will invariably come. Invariably, that PDA. So today also you will see the importance of it. It is so important, right? That is patent, that is ductus arteriosus, right? When it remains, it is called, when it is open, it is called as patent. Okay. So let's see this third point. The third point is that there would be development of some portion, some extra bud. Bud means to lung bud. With those lungs, they are just developing. Right? There is development of an artery for that lung bud. And when that thing happens, from beginning, that is that point of lung bud, right, to the entire lateral portion of this sixth one, it disintegrates. So that thing goes away. Now, this portion, which is the lateral portion, right, which is the lateral portion, this one is the lateral portion from lung bud to the lateral portion, this one, that disintegrates only on the right side. On left side, it remains. On left side, it persists. Because it is persisting, right, this remains there, so it persists on left side, and this portion, this small portion, which is called as the ductus arteriosus, and we'll see its importance, right? And so this ductus arteriosus is connecting what? This ductus arteriosus is, truly speaking, just from the figure itself, it is completely clear that those third and fourth, they were leading to the formation of aorta. This sixth one is for the pulmonary trunk. So it means this particular channel is actually a connection between pulmonary trunk and the aorta. Am I right? It is the connection between pulmonary trunk and the aorta. But this much understanding is sufficient. This is what is called as the ductus arteriosus, a duct into the aorta, which is starting from pulmonary trunk, right? This is very important. Okay, moving on to the fifth part. This fifth part is pretty easy. This fifth part tells just that it is from number 3, right? That is from the third arch. There would be development of external carotid artery. So that's good, right? Quite easy. So these were 1, 2, 3, 4, 5 points. Okay. So what we saw is first that in ascending aorta and pulmonary trunk, they are formed from truncus arteriosus, right? Truncus arteriosus, and then there were horns, and then there were all arches. So grossly, everything is from truncus arteriosus. That was the beginning. But when we talk about arch of aorta, that is just the beginning. So it is only on the left side, right? And it is the ventral aortic sac plus fourth arch artery. Yeah, because third and fourth, they are contributing total. Descending aorta, it is again only on the left side, because on right side it got disintegrated, and it is only the dorsal aorta, right, below fourth arch artery. Yeah, sure. See, just understand first this part, right, for this descending aorta. So step by step we'll keep on clearing the things. descending aorta, right? Descending aorta is this. So I am now taking another color, right? This is descending aorta. From where it is starting? It is starting from fourth, right? And why not from third? Because between third and fourth, so this ductus caroticus, it disintegrates. So third is disconnected, right? We are dealing with the fourth one. Third will be dealing with other carotid, etc., right? Those arteries. But over here, so we are talking about this. So very nicely this is done. That is what persists. This yellow portion that disintegrates. So this is how it forms, right? And for the ascending aorta and pulmonary trunk, right? They are from truncus arteriosus, yes, grossly. Arch of aorta, it is just from ventral aortic sac and fourth arch. So this is your truncus arteriosus, and from here it starts, and then it takes this shape and it goes all the way. And see, that's how the aorta is really formed, right? So this is a sort of summary, It tells truncus arteriosus for the arch, left side, and the fourth arch artery. Descending aorta is the dorsal aorta. Arch was the ventral aorta, right? And ascending was from truncus arteriosus. So practically speaking, it went something like this. So from truncus arteriosus, a small portion of aorta which is going up. Then we have got the ventral aorta, right? Ventral aorta along with the fourth arch. So this is one cut, this is the second cut, and this is the ventral aorta and the fourth one. And from here it goes back behind posteriorly. So this is the dorsal aorta, from which the descending, as it is going down, so it is called as the descending aorta. That's how it's formed. Right? Now regarding only the pulmonary trunk. So in pulmonary trunk, as we saw it over here, that yes, it is the sixth one which is getting involved, right? On left side, it is persisting as ductus arteriosus, and on the right side, that portion, that is the lateral connection and up to the lung bud, that is removed. That fifth was already been removed. So there is no connection, but there is some connection left out between pulmonary trunk, that is pulmonary trunk, and the aorta. So this is pulmonary trunk, right? This is aorta, and in between what we are getting, that is a ligament, that is a ductus arteriosus. Good one, right? So brachiocephalic trunk, how it is developing. Brachiocephalic trunk, it is developing from the, say this is which number? This number is number 4. 1, 2, 3, 4, right? 4. So over here, the portion of right horn of aortic sinus, it leads to brachiocephalic trunk. Why it is not happening on the left side? Because in left side, so this left horn of aortic sac, right? That is the ventral aortic sac, that was leading to the formation of ascending aorta. So ventral sac, ventral one, right? It was leading to the formation of arch of aorta and the end of the ascending aorta. So ascending, arch, and the descending. Ascending, arch, and the descending. So over here, it is the arch which is formed on the left side, and that's why brachiocephalic trunk, right? It is not forming any arch, it will just lead to formation of one particular trunk, and from that, those two arteries will go. That is common carotid, Okay, third arch on right side. See, this third arch which is on right side, right, as we said that it is taking part for the formation of external carotid. This third arch, it will be taking part into the formation of some other arteries also. That is for those rest of the small arteries, because what happens is that it leads to that vasculogenesis. So then all those small branches, they start emerging from it. Because we are not discussing every bit and small branches, right? So that is what really develops from this third arch. Similarly, over here also, whatever this third is left out, right, that leads to formation of rest of the small arteries, right? And that's why we discussed that vasculogenesis, because in initially initially those vessels, they are created, right, which are the early vessels, and then these are like finished products. So wherever it is needed, they'll keep on proliferating, then there will be formation of cavity, they will aggregate, and a new vessel will keep on forming, right? So that's how it goes. But this is about the main thing, that why arch of aorta, it goes posteriorly, and means it moves posteriorly, and the descending aorta, it goes absolutely on the dorsal side, because of this reason, that it is developing from the dorsal aorta, right? Dorsal component. Dorsal means it is behind. So right from the birth itself, right from the development stage, this is what really is happening. This is the reason why the descending aorta, it is also called as retroperitoneal. Retroperitoneum means in the abdomen, right? Everything is packed under like peritoneum. So some of the structures, they are behind this peritoneum, like kidneys, like this descending aorta, right? So they are behind peritoneum. So peritoneum is just a covering, and in peritoneum also there would be like a visceral peritoneum and the parietal peritoneum. Same the way we were understanding for pericardium, same the way it was like for lungs, that is the pleura. So this takes us to actually our today's most important session, that is the fetal circulation. Now in fetal circulation, it is like a story. What really happens? A very fast look at how the mature heart, it moves. So starting from, say, from the entire body, how it moves the blood from the entire body, the blood which is having lots of CO2, that would go from superior vena cava and inferior vena cava, right, and it will go to the right atrium, to via tricuspid valve, it will go to right ventricle. From right ventricle there would be pulmonary trunk. From pulmonary trunk it will go to lungs, where there would be the exchange of carbon dioxide and oxygen, and finally this happy blood, right, this, it will go into the left atrium, from left atrium to left ventricle via mitral valve, and from left ventricle it moves into the entire body via aorta. Things are pretty simple, right? From lungs, it will be going to left atrium via pulmonary veins, and they are divided like say 2 by 2, 2 on both the sides. Things are good, quite easy, right? But that's not the case when we are dealing with that gentleman who is sitting inside the womb, right? So in fetus, there are no lungs. There are no lungs. So the moment over here we say that there are no lungs, this entire component is lost. So that responsibility is to be carried out by someone, because lungs, one, they are not mature, and literally they are like drowned, right? They are fluid, because there is no air which is passing through that. So this oxygen, it has to come via placenta, because placenta is the connection between mother and the fetus. So whatever mother breathes, whatever the mother eats, that is all in the form of nutrition and oxygen is supplied to that fetus. Okay, so it is the placenta which is a junction, which is a junction. Now in pharmacology, right, when in the pharmacology after 3-4 days, when we'll be talking about, we'll be discussing one concept, that is some of the drugs, they cross placental barrier. Some of the drugs, they don't cross placental barrier. Then when we'll be discussing neurology, we'll be talking that there are some bloods which will be crossing blood brain barrier. Right. So what are these things? Why some are crossing, some cannot? Will it be having any significance? Well, definitely. If the drug can cross a placental barrier, that means if that drug is given to mother, it will be going via placenta into the fetus and it may affect. Right? Now, you have calculated, you are giving that dose with respect to height and weight of the mother. Now that can be a super overloading dose for fetus. True? So that's why in pharmacology we'll be touching some such aspects. That's why you must have read that for in many of the medicine it is said that this is not suitable for pregnant and lactating mothers, because those drugs, they are bound to cross these barrier and the kid or the fetus may be affected. One very, very important statement. The fetus never ever, never gets pure oxygen blood. No. It is always mixed. Now we might wonder that fetus is so important because it is the developing stage and everything is getting developed and still it is getting a mixed blood. There is no possibility of pure blood. Well, we'll try to find out the answer of this, that how it really happens that fetus always gets the mixed blood. So whatever the oxygen which is into that is what is utilized and rest is all given back. Right, let's start. So we shall be focusing on, no need to cram, no need to say remember every point, because this will come one after the other. But first we just understand that how much out of all these points, how much do we really remember? Umbilical vein and artery. Okay, umbilical. So this tells that we are dealing with the placenta, right? Placenta, because it is the mother who is connected to that fetus. So here is the placenta. So placenta is like a junction. So we write mother over here and fetus over here. So it is this placenta which is a barrier, and out of that some veins and some arteries they are going. Now when we say umbilical vein and umbilical artery, so which, with reference to what? With reference to fetal heart, because now there are two hearts, correct? There is one heart of mother and then the second heart of this fetus. So it is with reference to fetus. And we said that anyone which is coming towards the heart, coming to heart, it is vein. So it means we are dealing with this. The vessel which will be going from placenta to fetus, will call it vein. Umbilical vein. Umbilical vein. And when from fetus it is going back to placenta, so we shall call as umbilical artery. Simple as that, because everything is in with reference to fetal heart. So this part is now known to us. Ductus venosus, halt, right? We'll come to that. Foramen ovale, yes, we do remember this foramen ovale, because during that atrial septum formation, there was a development of high speed we go. There was septum primum, right? Then it was getting, then there was like ostium primum over here. Then this septum primum takes all the way, but then it develops some gap on the posterior side, and that is what is called as the ostium secundum. And then there is development of one other septum, and that is what is called as the septum secundum. and then there is some gap between both of them, and this is the gap, and that gap is what is called as the foramen ovale, right? This is the right atrium, this is the left atrium, right? So we are dealing with between right atrium and left atrium. So that's the shunt, shift of blood from one point to another point is we are talking about, that is foramen ovale. And in anatomy we saw that this foramen ovale is seen as fossa ovalis, right? So same thing, it is just a monument of that foramen ovale, that once upon a time there was foramen ovale, and now it is fossa ovalis, a depression which is oval shaped. So that is the landmark. Ductus arteriosus we just studied. We just talked about that on the left side there would be a connection between pulmonary trunk and the aorta, right, through which the blood can really go on either side. There is no valve, it is just a tube which is connecting both of them. So we'll see that what really happens. So these are the areas. Ductus venosus, yes, we'll come to that, right? So when we'll study, we'll put a tick over here. Let's start. First, we talk about liver. See, liver has got, normal liver, right? Liver has got two inputs and one output. Liver has got double blood supply. One is the portal vein, and second is hepatic artery. So why such? Why two things? Whatever you eat, everything, right? Everything is digested, and then it is absorbed, it is picked up, and then it is taken to liver. Liver would say, okay, whether you have come up with the nutrition or you have come up with the waste, it is me who has to process everything. So liver is our chemical factory. So just remember, all those things, they are brought to liver by portal vein, right? Portal vein gets everything. Liver would say, I need to work, right? I need to work. If I have to work, I need oxygen. So hepatic artery would say, I'll provide that oxygen. So that's the reason there are two supplies. One supply which is getting the raw material, that it is this material on which you have to process. And hepatic artery is saying, okay, I'll supply the fuel, and it will supply the fuel. So it is the portal vein and hepatic artery, they both enter. Right? That's why there is something what is called as the hepatic triad. Hepatic artery, portal vein, and bile duct. Because function of liver is to produce bile, which will be playing an important role into the digestion. But because it is a separate topic, right now we are not talking about it. But because hepatic triad means three things, they are combined over there, and third is the bile duct. So that's why I'm mentioning it over here. Okay, liver works very hard, and then finally it says, okay, now I have to, from where the blood should go out, it will say, okay, it has to go via this vein. So that is the hepatic vein which takes the blood out. Obviously in hepatic vein there would be CO2. O2 has been utilized. Correct? O2 has been utilized because of that metabolism. So this is a normal liver function, how the liver works, right? Because liver is our chemical factory. Things are good when it is like a mature liver, right? In you and me, that's how it works. But again, when it comes to someone who is just sitting inside the womb, he'll say that, see, I don't eat, I don't drink. It is the mother who is supplying everything. So when that supply is coming via, again, same placenta. So from placenta, here comes the umbilical vein. This vein is going towards the fetus. So that's why we are calling vein, right? Because it is with respect to fetal heart. And this umbilical vein, just there is one umbilical vein, and it divides into right umbilical and the left umbilical. Now listen carefully. Right umbilical vein, it will land into portal vein. This portal vein was basically what? Portal vein was that which was carrying all the nutritions and toxins, right? So if someone has taken alcohol, so that is also to be processed by liver, and if someone has consumed fruit juice, so that also is to be handled by liver only. So it is this portal vein who is getting all these raw stuff, right? Okay, chalo, process it. Hepatic artery to is over there. It will say, okay, I'll keep on supplying the oxygen and you work on it. Fine. So right umbilical vein with all those nutritions, right, it is dumped into the portal vein and portal vein will take it inside the liver to metabolize. Simple. Liver will say, yes, I'll work. Liver will start working on it, right? So even if this person is sitting inside, still his liver is working, right? It works and it grows in its size. So that's how things go. Okay, oxygen, nutrition, everything given, utilized. So now blood will come out. It has to come out. It comes out with CO2, carbon dioxide, because oxygen has been utilized. It goes into the hepatic vein. This hepatic vein, it opens into inferior vena cava. Now it is making sense. It opens into inferior vena cava, right? From inferior vena cava, we know that it lands into right atrium. So in right atrium, it goes. So remember, it is having CO2. It is having CO2. Purely unhappy blood. From placenta to happy blood is coming, right? Something who has got oxygen, but this oxygen is utilized over here. But no problems. There is left umbilical vein also. This left umbilical vein is having oxygen. So it gets opened into straight away IVC, inferior vena cava. And this special area is called as the ductus venosus. It is a vein duct, a specific duct, and the purpose is to bypass hepatic circulation, because we know that liver is going to use the complete oxygen. So that's why if we bypass it, so in that case the oxygen should be able to reach to IVC, and that's what really happens. So in IVC, in inferior vena cava, the deoxygenated blood from the liver and the direct blood which has been bypassed from hepatic circulation, that lands over here. So this is where there is a mixed blood. This mixed blood will reach to right atrium. This inferior vena cava will open in right atrium, right? So it will reach to right atrium. Now see what happens into right atrium. Here is the right atrium. Superior vena cava will also land, but superior vena cava, so it is just getting the blood from head and neck, and they all are utilizing, right, in the development, in the growth. So there is no chance that any of the oxygen is left out. So it simply gets carbon dioxide wala blood. And this inferior vena cava is getting the mixed blood. So this mixed blood, it comes to right atrium. From right atrium, it goes to right ventricle. It should go to right ventricle. But this is having less oxygen and more of CO2. Okay. And from here, from right ventricle, there is pulmonary trunk, right? And pulmonary trunk would take it to, lungs. It would take it to lungs. So lungs would say, see, we are on vacation, right? We are just kids. We are not good for any of that oxygen CO2 transfer. Don't give this responsibility to us, because we are to sitting in a fluid. We are drowned. We are just increasing in our size and we are developing. So we can't work. So even if you send the blood to us, it's of no use. In fact, we'll offer resistance that you don't send anything to us. Now what to do? Where the blood should go? So here it is. Fetus lung, technically speaking, what we personified over here, right? When the lung said we are in the vacation mode, actually it is like this, that those fetus lungs, we know that the smallest component of the lungs, that is the alveoli, right? That is where the oxygen carbon dioxide exchange occurs. And surrounding the alveoli, there are arterioles. Now these arterioles, as there is no oxygen, so that means it is called as when there is no oxygen, it is called as the hypoxia, right? There is hypoxia. And whenever there is hypoxia, it leads to the condition what is called as hypoxic pulmonary vasoconstriction. Vasoconstriction. Vessels are constricted. When the vessels are constricted, and if you try to push the blood into that, if you try to push the blood into a narrow vessel, so there would be lots of resistance. So there is increased resistance in arterioles because they are constricted. Correct? And at the same time, lungs are telling, see, there is no oxygen. So even if the blood comes, what shall we do? Because there is no oxygen, so don't come. So that's why they will narrow down their gates, right? They will narrow down their gates. They are constricted. It's okay, lung has done this. But the back pressure, that back pressure, when it is blocked over here, that back pressure will be mounting over here into the right ventricle. Because from right ventricle, blood is not going further. Okay, so pressure is increased in right ventricle. Again, the back pressure, that thing would mount on right atrium. So now right atrium is under high pressure. Got it? This is right atrium is under high pressure. Now heart would say there has to be something to manage this. Getting it? Right? So this is like, we have come to this conclusion that right atrium is under high pressure. That's where our foramen ovale comes into picture. This is where foramen ovale comes into picture. What foramen ovale tells, for this day only I kept this foramen open, right? So it will say this is septum secundum, this is septum primum. This septum primum is like a membrane, right? So when on the right side, this is on the right atrium and this is the left atrium. So from right atrium, when our pressure is more, when we'll push this septum primum will go, and then there is a formation, right, of such a nice foramen, and the blood would start flowing all the way from right atrium to left atrium. All good, right? Because there was no point in going down, because lungs as such, they were telling that no, will not work. So the blood now goes from right atrium to left atrium via foramen ovale. So that's the foramen ovale. Okay. Moving further. You worked so hard, right? You worked so hard. All the way the blood has been carried to the left atrium. True? From left atrium. From left atrium, from where it came? It came from right atrium. Via what? Via foramen ovale. From left atrium, it will go into left ventricle. Correct? From left ventricle, it will go into aorta. Everything is looking so good. Right? Everything is looking so good. And from aorta, it would be circulated into the entire body. So far, fine. But still, something is like not good. And what is that? That is, say, from right atrium, it is said that yes, you send the blood to left atrium because left atrium is someone who will be taking this blood to the entire body. Some blood still, not understanding this situation, they will go via tricuspid and they will go into the right ventricle. Still, right? In spite of telling so many times, they'll say, no, we are going into right ventricle. Well, it goes into right ventricle. Right ventricle would say, okay, fine, I have got only one exit, and that is what? That is pulmonary trunk. Pulmonary trunk. And blood would be pushed. But it will say it is the dead end on right lung, it is dead end on left lung. Now what to do? That is where the ductus venosus comes into the scene. Ductus venosus enters. Ductus venosus tells that for such notorious blood, for this naughty blood, which was not understanding that we should go via this foramen ovale, it will say, here is your another channel. right? So all the blood which you are going via this route, right, go via ductus arteriosus into the aorta. See how smart it is, right? It will say go via ductus arteriosus, and it will via ductus arteriosus, it will land into the aorta. Done. So it means either the blood, it went into aorta via left ventricle, or the blood which escaped into the right ventricle, it went into pulmonary trunk, and from pulmonary trunk it again went into aorta via ductus arteriosus. So nice, right? Very nice mechanisms. So one was this area and second was this area. Now technically speaking, right, we draw it like over here, but where exactly it is, here is, this is the portion, this is ductus arteriosus, right? And in adults, that is, once the baby is born, there won't be such shunt. Ductus arteriosus, it won't be needed at that point. Right? We'll see that what really happens to ductus arteriosus, but its final outcome is it is blocked. When it is blocked, it gets converted into specific ligamentous structure, and that's why it is called as the ligamentum arteriosum. Ligamentum arteriosum. So ductus means duct when it was open. So now this is what we are watching is ligamentum arteriosum, because this is an adult heart. Most difficult portion has been completed. So from this point, right, the bird's view, right atrium to left atrium, it goes via foramen ovale, right? Some of the blood will go into right ventricle. It will reach to pulmonary trunk, and that's where the ductus arteriosus will come into picture. That was foramen ovale. Ductus arteriosus will come into picture, and finally the blood will reach to aorta. Whether it is via this route or it is via this route. Okay? All right. Now this ductus arteriosus is, there is a control. That control is in the hands of placenta. Placenta will release prostaglandins, and these prostaglandins will keep on telling ductus arteriosus, remain open, remain patent, right? You can't sleep, remain active. So ductus arteriosus will say, okay, because this is coming from headquarter, right? So I need to work, so it will remain patent. It will remain intact. That means the channel would be remaining established between pulmonary trunk and the aorta. Okay. Next, we start with the return journey. Say finally the body got what? Mixed blood, but that's okay. It will say, yes, that's what is in my fate, right? It's like only after I am born, right, I can get the pure blood, otherwise I have to compromise with this mixed blood only. So that's how it works. Now the return journey. The return journey is, say, it is distributed across the whole body, right? Now this aorta, right, when it returns, right, this is the descending aorta. Via this descending aorta, it divides into common iliac artery, right? Then it divides into external and internal, and then there were arteries over here, right? That was brachiocephalic trunk. Then there was common carotid, which was going into the brain. Then there is subclavian, which was going into upper limbs, right? So everywhere, and thus it is moving to all those places. And from there, from everywhere, the blood was getting collected, and by IVC and SVC, inferior vena cava, superior vena cava, they collect the whole blood, and then once again they put it into right atrium. That's how things were going. Right? What about lower limb? Well, for lower limb, here is the common iliac artery, and this is the external iliac and the internal iliac, and this external iliac, it goes to the lower limb, it supplies lower limb, femoral and other vessels would come, and the lower limb is also supplied. Everyone would collectively finally dump into IVC or upper says SVC, and they will go into right atrium. But then there is some change. Rest of the body is fine, but this internal iliac would say that we need to take responsibility of sending this unhappy blood and which has got no nutrition back to the headquarter, that is the placenta. So then it goes from internal iliac artery, right, that continues as the right umbilical artery and the left umbilical artery. So these two, they will actually wind around. So that was the umbilical vein, and then this winds around, right, it winds around that umbilical vein, and this entire thing is packed into a jelly like substance which is called as the Wharton's jelly. This Wharton's jelly is temperature sensitive. So when there is so cold, so dark inside the womb, so at that point this Wharton's jelly is into its liquid state, right, it is into semi-liquid or jelly state. So it is protecting all these umbilical arteries and umbilical vein. And the placenta, it takes the responsibility of CO2, O2, nutrition, right, all those things, they are taken care of. So that's how this circulation, it keeps on moving on and on and on, right? So very important points to note is that just in 1 minute, if we say placenta, from placenta there goes umbilical vein which will divide into left and right, it will open into that portal vein, right, and then it will go into the liver. Liver will utilize everything, right, it will utilize this nutrition, it will utilize this oxygen, and that thing comes out in the form of, say, hepatic vein. This hepatic vein would open into inferior vena cava. Meantime, there is a left branch. This left branch will say, I'll generate one extra channel, right? One extra channel. That extra channel is what is called as the ductus venosus. This ductus venosus is done. So now we have got the mixed blood over here. This mixed blood from IVC, it will be landing into right atrium. From right atrium, it will try to go to right ventricle. From right ventricle, it will say, I'll send it to pulmonary trunk with the hope that lungs would work, but there are no lungs. So what would happen? It will say, okay, let's have a shortcut, bypass. That bypass, which will now call as the, over here, it is ductus arteriosus, right? Ductus arteriosus. This ductus arteriosus will send this pulmonary trunk to connect it to aorta. So now aorta is having the entire blood. Meantime, one more thing happens, that is from right atrium, it goes to left atrium via that foramen ovale, right? And from right atrium, it will go to, from the left atrium, it will go to left ventricle and it will go to aorta. Finally, aorta has got the whole blood, and from aorta, it will go to the entire body. The rest of the arteries, though they are fine, but then there is like internal iliac, right and left, internal iliac from right and left, and they will be going into the form of umbilical arteries, and then it will finally end up into placenta, right? So that's how this circulation, and over here placenta. So from mother side, once again, oxygen, carbon dioxide exchange plus nutrition the fresh nutrition is taken and then it is pumped and it keeps on moving on and on and on, right? And over here, so we saw two things. Umbilical vein is one and umbilical arteries are two, right? Because we have got left internal iliac and it goes as left umbilical artery, and the right internal iliac is the right umbilical artery. So what is there into placenta? We have one umbilical vein and two umbilical arteries. Remember, these are called arteries or veins with respect to that chota sa heart which is beating over here. That is the fetal heart. So you'll say this vessel is coming towards me, so I'll call it vein. This vessel is going away from me, so away is artery. Okay. All right. Now here is the baby. Baby is born, and its first cry. This is what is called as vagitus. This is the British English where they have given a word for that first cry. This first cry is vital. That's why if the baby is not crying, so then even the pain impulse is given to that baby. That baby is slapped on the back, right? Because that generates so much of pain that it fires the brain and it leads to that first gasp, first breathe. Baby must breathe because lungs are drowned. So you have cleared everything, but now that baby should initiate that first spark, right? So that is the first cry. The moment baby cries, lots of air is pushed into right lung and the left lung. Fine. Oxygen goes. The moment oxygen goes, first thing which is eliminated is hypoxia. Now there is no hypoxia. Hypoxia itself means lack of oxygen. So now there is no hypoxia. If there is no hypoxia, so then there is no vasoconstriction. So pulmonary vasoconstriction which was there, that is now eliminated. Right? That is eliminated. The moment it is eliminated, it means vessels would dilate. Now those vessels are dilated, vessels are happy. Since long they were all constricted, right? So they are dilated because oxygen came, right? Oxygen came. In presence of oxygen, these veins, these arteries, they also started feeling good, these vessels. So they are like they are dilated, vasodilated. The moment they are dilated, they are big vessels, there is decreased resistance. Resistance is decreased and it will say, okay, let the blood come. Now over here, right atrium to right ventricle to pulmonary trunk, and now it is going towards all those arterioles, right? Pulmonary trunk, right pulmonary artery, left pulmonary artery, then they divide, but final output, right? They divide. Finally they reach to arterioles where there is no resistance. The moment the resistance over there drops, immediately the back resistance everywhere drops. Resistance in pulmonary artery drops, resistance in right ventricle drops, resistance in right atrium drops, pressure drops, right? Pressure drops into right atrium. When this pressure drops, it means there would be relatively high pressure, right? I'll write the word relatively high pressure into the left atrium. When there is relative high pressure in the left atrium, blood will try to go from left atrium to right atrium. That's where our smart septum primum comes into picture, right? He is septum primum. Septum primum. Septum primum will say, for this day only, I was made so thin and with a wall-like structure. The moment blood tries to go back, he snaps, right? It is closed, right? It will say, now I won't allow the blood to go on the opposite side. Because previously the pressure was high over here, so this was like a flap. It used to swing, and so that the blood was going. Now it is snapped, right? It won't allow. So foramen ovale in nutshell, it is closed. Foramen ovale is closed. Till this pressure is maintained, right? Foramen ovale is not going to remain open. But as the lungs are always there, right? Lungs will always keep this right atrial pressure low. So this flap will remain as it is, and slowly and gradually it fuses. It fuses. right? It fuses. So that's the reason that as a monument, this space is then left as it is. And that's what in the normal anatomy we see as fossa ovalis. Fossa ovalis, right? Okay, still more things to come. So understood this. Right atrium to left atrium, right? That thing now won't go because foramen ovale is closed. This direction is closed. Right ventricle to pulmonary trunk, things are good, right? And from here it is going to lungs. Lungs are happy, things are good. From left ventricle, yes, left atrium to left ventricle to aorta, there is a ductus arteriosus. Ductus arteriosus would say I am just a channel. I'm just a channel, right, between pulmonary trunk and the aorta. So it's okay. Previously I was sending the blood like this. I don't have anything like valve. So now the pressure over here is reduced. So I'll start the return blood. From aorta it will start transferring to pulmonary trunk. Yes, it happens. It happens. But this is temporary. Why temporary? One. I'll take this point first. This one. This ductus arteriosus was dilated because placenta was telling. Placenta was telling that, okay, I'm sending prostaglandins, and those prostaglandins they tell that placenta has said that you remain intact. But now, after delivery, the placenta is no more. If placenta is no more, so then there is no question of prostaglandins. In absence of prostaglandins, this ductus arteriosus becomes udas, right? He tells now there is no one, okay, and it shrinks. It shrinks. So that's why that return flow, it continues, but it is only temporary. Till ductus arteriosus realizes that now there is no prostaglandin, there is no one to tell me anything, so it shrinks. Also there is constriction of ductus arteriosus because now there is no hypoxia. There is no hypoxia. There is no lack of oxygen. Oxygen is there. So ductus arteriosus finally feels that there is no point, now there is no importance of mine. So after a few hours it becomes flat and it gets converted into ligamentum arteriosum, right? And it remains there for rest of the life, right? In that memory that once upon a time I was transferring blood from pulmonary trunk to aorta, but gone are the days. So now I am just sitting ideally in the form of a dead ligament, a small ligament which is present, right? Okay. So we have two umbilical arteries and one umbilical vein. They are there, right? Still they are there because placenta we are about to remove. The moment the baby is delivered, immediately that Wharton's jelly will say, because it is so temperature sensitive, it will say everything was so cold, clammy, dark inside, and now situation is different. So this Wharton's jelly will shrink. When Wharton's jelly shrinks, it also shrinks, squeezes those umbilical vein and umbilical arteries, right? So they both squeeze. So it means now umbilical vein and umbilical artery both are squeezed. This is what really happens. It shrinks. So this is, we are dealing with umbilical vein. This umbilical vein squeezes, right? When it squeezes, it means this portion is lost because it would be cut. It would be cut, right? When you will be removing placenta, even this cord is also cut. So it will be cut. So in that case, that right umbilical vein, which said that I will be there, I was there to talk to portal vein. Now portal vein will say, okay, I am doing my work. Now this right umbilical vein is no more needed. So obviously that portion of vein which is now not doing any work it gets converted into again a ligamentous structure, and that is what is called as the round ligament of liver. So actually when you dissect liver, when you see, you will be able to see this round ligament of liver, which is also called as the ligamentum teres hepatis, right? It's just the another name, aka ligamentum teres, that is into the liver. So which is in the remembrance or of right umbilical vein, remembrance or the remnant, right? Remembrance because it becomes, you try to remember it easily, but otherwise they are technically called as the remnants of right umbilical vein. Okay, so that is one. What happens to this left? Because left umbilical vein, that was also very adventurous, right? Left umbilical vein was telling that I am passing the blood which has to bypass the hepatic circulation and I'll be pushing it into infra vena cava. So again the supply has stopped. So this left umbilical vein, right, this left umbilical vein, that also becomes sad, right? That also becomes sad, that now there is no need of me. Yeah, it will say, no, this ductus venosus is no more needed because there is no blood which can really be taken to IVC. So this is also gone. So it will say, okay, one more remembrance, ligamentum venosum, right? So ligamentum venosum it gets converted into that in the memory of ductus venosus. So thus we have got the round ligament of liver or the ligamentum teres and the ligamentum venosum, and during liver discussion, during the dissection of liver, all these ligaments, they can actually be seen in the form of a very fine thick folds, right? Because they were actually good powerful veins who were keeping the entire fetus alive. Okay, only one problem has remained about that umbilical artery, right? So this was our descending aorta, which was divided into common iliac artery, right? C is common, right and left, yeah, right, right and left. And again common iliac was divided into external iliac artery and internal iliac artery, again right, right, and over here also same way, right? External iliac artery and internal iliac artery. From these internal iliacs, right and left, they both were forming umbilical artery, and it was that umbilical artery which was going towards the placenta. Placenta was here. Again, now the placenta is not there. Even this Wharton's jelly, right? Wharton's jelly has also shrunken. So there is no blood, there is no path, and none of the blood they can now be taken to, say, this placenta, and more or less this entire thing is now cut also. So this internal iliac would say, okay, it's okay, whatever has happened, right? Now we are not needed, but there is someone who is really needing us. And who is that? He'll say this is the area where the urinary bladder is there. Urinary bladder. So this urinary bladder is requiring some blood. So why don't we use our rest of the arterial portion for that? So the proximal portion, right? Proximal means something which is near, distal is far. So this distal portion, that is degenerated, that is removed. But this proximal portion, they say that we make our life worthwhile, and they supply to urinary bladder in the form of superior vesical artery. Vesicle means bladder, vesicle means vessel, right? So this is vesicle. It is a vessel in which the urine is collected, right? So urinary bladder is basically like a vessel. Its function is just to collect the urine, right? From the ureters it comes, and it has got detrusor muscles. Those muscles, they are so flexible, right? So as the impulse comes, it is a very finely tuned system. So when the urine comes, when it is collected, So then there would be stretch receptors. So they will say, okay, need to go to washroom. But system would say, no, right now there is no such condition. Immediately the message would come, detrusors, relax, right? So they just relax. Bladder size increases, stretch sensation goes away, and person goes back to normal work. So this is like an automated process. The day this system is affected, it would happen that now there is no one to tell bladder that okay, relax, right? Let the urine be collected, don't contract. Now because that sensation has gone, so what would happen? Bladder will start working by itself, and that is what is called as automatic bladder, right? That's how you learn the neurology part. Anyway, coming back to this, so these vesicles, superior vesical arteries, these are the blood which is given to urinary bladder. Thus everything is set and systems keep on working in the adults. So this was the fetal circulation, right? This was for our today's session. Now what we do is, just in 5 minutes we go for high speed revision, right? Every point would be discussed but at a higher pace, right? Okay, let's start. Going back, so welcome, and yes, that's fine. As I could see the comments, say tomorrow is no, day after tomorrow, right? Tomorrow we'll be discussing physiology, and on 31st, yes, we'll be having this session on how to plan or how to schedule our entire medical studies. This planning is not like that you have to study, I'll say that you have to study from say 4 o'clock in the morning to 6 o'clock in the morning. There are advantages of waking up earlier, but no, we won't be discussing it. We'll be discussing it very grossly. That is how you should plan your weeks, months, years, right? Within what time frame you should complete at least this much subject. Say anatomy, by what time, irrespective of what is taught in college or you are learning from anywhere, but you took the admission, you know that the target is exactly 5.5 years from now. You know that your USMLE exam, in case if you are planning, so it is on this date. By that date, you should be completely ready, right? So that would be like an impeccable planning, how you should do, how should you cover all those subjects as per the weightage, because see, no one comes with that super extraordinary robotic brain that once you have copied anything into brain, you remember it forever. No, there are chances, and it would happen that you'll start forgetting the things. Then how to take care of it? How to remember it so crisply that you put less load on your brain, but you still remember it, right? So that's what we shall be discussing, and then the complete plan. That as if today you have taken the admission, then within 1 month you must cover these many topics from these subjects. These topics within the span of 3 months. 3 months have completed. So now you have to revise these topics. So sit on one of the Sunday, revise everything, and now you are good to go. How to make those notes, that is what is called as high speed notes, right? Even we'll see that also. One of the example, start your clock, within 5 minutes we are revising everything, and that's how you have to revise. That's how you have to revise, and you revise this thing only twice, and that twice is just before you go to sleep and as soon as you wake up in the morning, right? This is how the revision should go by, and our time starts now. So we talked about aorta, ventral aorta, first aortic arch, dorsal aorta, right? And the heart tubes, they fuse, right? Those aortas, they fuse, and then there is development of those, say, aortic arches, right? In these aortic arches, 1 2 3 4 5 6, we just see 5 disintegrates. It is 3 4 and 6, they are important. 6 with respect to this pulmonary trunk. First is maxillary artery, and the second one is stapedial artery, which remains into fetal life for some time, and fused dorsal aorta, and that's spiral one which we are talking about. So just one word, spiral, or we just draw like this, it is sufficient, right? This is good fetal life, and it takes part into this external carotid artery formation. Fifth disappears without anything, right? Third, fourth, they are forming the aortic sac, ventral port, and this is the dorsal part aortic sixth. This is what will be developing the pulmonary trunk. Okay, that's what is called as the spiral septum or aorticopulmonary septum. To produce adult pattern, ductus caroticus between 3 and 4 that disintegrates, done. There is only on the right side force to that fusion, so this entire thing goes, so only this survives. So actually the aorta will be going over there. So that was the second point. The third one, this is to the lung bud, so even this thing goes away, right? So on, but only on the right side. On the left side it persists as ductus arteriosus. Now we know it very well. Ligamentum arteriosum, good. Pulmonary trunk, aorta, nice, right? And from the top, external carotid artery and other arteries, they will be developing from this third arch, right? So for aorta and ascending aorta and pulmonary trunk from truncus arteriosus, arch of aorta from ventral aortic and the fourth arch, and finally descending aorta, it is below fourth arch, because above between 3 and 4th, that was dorsal caroticus, which was degenerated, and this is dorsal aorta, right? That's what we get, and this is for the brachiocephalic, right? Brachiocephalic, it develops from the right horn, and ventral aortic from the ventral dorsal aorta. Fetal circulation, a normal circulation, we know this part, right atrium to right ventricle, pulmonary trunk, lungs, and this is the happy blood into left atrium to left ventricle to entire body, and through body they utilize and then they return. That's the mature one. In fetus, no lungs, so no maturity. Placenta is responsible for this oxygen, mother to fetus connection. And there is placental barrier, blood-brain barrier. These are all those pharmacological points we talked about. Fetus never gets pure blood, so that's the important point. Always a mixed blood. We will be focusing on umbilical vein arteries, ductus venosus. Now we know ductus venosus and foramen ovale and the ductus arteriosus. That's what really happens from placenta, right umbilical vein and the left umbilical vein. Right umbilical will go into portal vein. Will consume all oxygen, nutrients, and will send final products into hepatic vein, which is having carbon dioxide. It is sent to IVC in vena cava. Meantime, there is ductus venosus. This ductus venosus function is bypass hepatic circulation, right? And it will go into the form of mixed blood into IVC, and it goes into right atrium. We are into right atrium with the mixed blood. Right atrium would try to send this blood to right ventricle, right? And over here, there is less oxygen, there is more of CO2, but whatever over the lungs, there is so much of resistance, right? That's why it comes under high pressure. Why should it happen? Because of hypoxic pulmonary vasoconstriction. Constriction means narrowing. So there is high pressure. There is high pressure, this back pressure, it leads to back, it goes to the high pressure in arterioles. So then right heart is under high pressure. It goes back from pulmonary artery to right atrium to right ventricle, right? All those, everyone is under high pressure. This high pressure will trigger the opening of that gate, right? That is foramen ovale. That's the hero of this part. So it is where the septum secundum is there, but it is the septum primum which flaps and the blood goes into the left atrium. From left atrium, it moves further, but some of the naughty blood from right atrium, it goes into right ventricle. No choice, it will go into the pulmonary trunk, but there is ductus arteriosus. It will push it into aorta. Finally, everyone is happy. The blood finally reaches aorta, and from aorta it goes into the entire circulation. That was the location of ductus arteriosus, right? Later on gets converted to ligamentum arteriosum. So that's what was like a bird's view: right atrium, right ventricle, pulmonary trunk, foramen ovale, ductus arteriosus, and this is good. Important point to note, these are the prostaglandins. So this is our headquarter, and who sends a messenger, prostaglandin, that ductus arteriosus, you remain intact and keep on doing your work. Return journey, right? As it goes from aorta, it divides into common iliac, and these internal iliacs, they are the right umbilical and the left umbilical arteries, because these are arteries, they are with respect to the fetal heart, So that's why they are arteries. And the blood is taken to the placenta, which is covered by this Wharton's jelly, extremely temperature sensitive. In the cold environment, it is all good, it is dilated, so all these umbilical veins, arteries, they all are intact, right? And that's how things go. Baby is born, first cry, that's what is called as the vagitus. This is air, it goes into the this oxygen, it goes into the lungs. No hypoxia, pulmonary vasoconstriction removed, so it is dilated, resistance decreased, and all the way when the pressure drops, so it closes this foramen ovale, and now it is converted into what's called as the fossa ovalis, right? Same way, everything goes good, but it is this ductus arteriosus which is a patent structure. It will start return journey of that blood, but the moment there is lack of prostaglandins and then there is no hypoxia, it is constricted in the absence of prostaglandins, and those two umbilical arteries and one umbilical vein, they'll go for constriction, because even Wharton's jelly, that is also constricts, it squeezes both of them, in fact three of them, one umbilical vein and two umbilical arteries. So right umbilical vein, it is now round ligament of liver, a remnant or the remembrance of once upon a time right umbilical vein, and the ligamentum venosum, that is in remembrance of left umbilical vein once upon a time, right? Finally, the descending aorta, those vessels, they are umbilical arteries, right and left. They also degenerate, but their proximal portion, they say that yes, we are useful to someone who is near, and that is urinary bladder, so they will form themselves, they will remain themselves into the form of superior vesical artery. Vesical means vessel, and that is urinary bladder, right? So this is how you will revise. It just took 5 or 6 minutes. So that's how you will revise, and it would be so effective once you do it before you go to sleep and next morning when you wake up, because that's the portion when your brain is in its most absorptive stage. So these are the stages, just 5 minutes before you go to sleep and as soon as you wake up, right? So thank you so much, and tomorrow we shall be discussing the physiology of heart. Thank you and take care. See you. Bye bye.